the role of SGLT2 inhibitors in chronic kidney disease. As Joseph already pointed out, SGLT2 inhibitors have revolutionized, in fact, revolutionized the treatment of diabetes, and the role of this has been expanding for the past few years. Initially started as an anti-diabetic drug, but then it was found to have cardiovascular renal benefits, and the benefit has extrapolated to kidney patients as well as patients with diabetes, those with non-diabetes as well as heart failure. So the next few slides, I'll be going to explain on the current role of SGLT2 inhibitors. As you all know, the prevalence of CKD is increasing worldwide. Am I audible?
Yes.
Yeah, you are audible.
So I just want to, as I already pointed,
share the slides, sir. That is what
slides are not visible. Just a second.
No, slides are not coming.
Just a moment. Is it visible now?
Yes, they're visible.
Okay. So going on to the topic. So CKD, the prevalence of CKD is increasing worldwide. Approximately 2.6 million people are receiving renal replacement therapy, and it is costing about 1.2 million deaths annually. And if you look at the etiology of CKD, diabetic is the most common cause of CKD, contributing around 50% of patients with end-stage renal disease. And so the mortality due to CKD has not improved much over the years, wherever when you look into the other conditions. And in fact, the number of patients who are receiving renal replacement therapy has also been on the rise for the last few years. And the mortality as well as morbidity of the associated with CKD increases as the stage of CKD worsens. Those with end-stage disease has got high cardiovascular mortality, and in fact, they die of cardiovascular disease rather than going into end-stage renal disease. So CKD is associated with cardiovascular morbidity as well as mortality. So there is atherosclerotic cardiovascular events like coronary disease, ischemic stroke, and there is other non-atherosclerotic events like arterial calcification, arrhythmia, sudden death. So these are more prevalent as stage of CKD worsens. And patients with CKD are also at increased risk of heart failure. So to improve the outcomes of patients with diabetes and CKD, the progression of CKD has to be curtailed, as well as the cardiovascular outcome also has to be improved. So risk of mortality increases and regardless of the diabetic status, and the leading cause of death in CKD patients are cardiovascular as well as non-cardiovascular causes. So if you look at the traditionally, the outcome trials have focused on patients with type 2 diabetes, has focused only on patients with type 2 diabetes, and some of the early studies have looked into ARBs, thiolysquirin, dabigatran, etc. And there have been not many molecules which have curtailed the progression of CKD over the last 10 years. And in fact, AC and ARBs were the drugs which were the only drugs which were available to prevent the progression of CKD. So there was that unmet need, and that was when in 2015 the first SGLT2 inhibitor was launched. So SGLT2 inhibitors are a new class of glucose-lowering drugs which work by blocking the low-affinity, high-capacity SGLT2 receptor, which are located in the proximal convoluted tubule. And this SGLT2 protein is present on the proximal the proximal tubule, and the majority of reabsorption of glucose takes place in this aspect. That's around 90%. And SGLT2 inhibitors block this and prevent the reabsorption of glucose, and this results in glycosuria as well as natriuresis, as the protein is a co-transporter, and they lower the blood glucose by preventing the glucose and sodium reabsorption in the proximal tubule. Now, just going back to history, the first drug was a fluorescein, which was a natural product which is used to treat this infectious disease, and this was isolated in 1835 by a French chemist. And then this fluorescein was found to block the glucose absorption in the kidney, and by inhibiting this SGLT2 family of proteins, and these include various SGLT1, the two which is located in the proximal part, and the distal part as SGLT1. The fluorescein was a non-specific inhibitor. It was inhibitor of both SGLT1 and 2, and SGLT2 is apart from the kidney, it is also located in the small intestine, lung, heart, and liver. So fluorescein had its side effects of gastrointestinal and low bioavailability, and it was only in 2015 when the selective SGLT2 inhibitors became available. And the mechanism of SGLT2 is unique compared with other glucose-lowering agents because it does not interfere with the endogenous insulin or the incretin pathways. And some of the SGLT2 inhibitors which are available are the canagliflozin, the dapagliflozin, then empagliflozin, ertogliflozin, sotagliflozin, which is a combined inhibitor, and then pexagliflozins. These are the SGLT2 inhibitors which are available. And now let us look into the mechanism of action of this SGLT2 inhibitors. So SGLT2, as already said, is located in the proximal segment of the proximal part of the earliest X1 segment of the proximal tubule, and this blocks the proximal glucose and sodium reabsorption, as a result of which increased sodium is available at the distal tubule or the macula densa, which senses the increased delivery. And this may result in restoration of the tubular-globular feedback, and there is an increased distal delivery of sodium, and there is activation of adenosine, and which will cause the efferent arterial vasoconstriction, and at the same time the efferent arterial is not affected, and this will result in a decrease in glomerular hyperfiltration and a decrease in pressure within the glomerulus. This may result in decreased proteinuria. So the additional downstream effects like decreased urinary albumin expression may reduce the pro-inflammatory pathway activation as well as the direct tubular toxicity. And there is improved cardiac function, and there is increased hematocrit concentration, which may result in the increased oxygen delivery to the kidney, because the reabsorption is an active process, requires energy. There is the energy utilization is changed, and there is increased oxygen delivery, and there is improvement in renal hypoxia, and this may result in increased hematocrit as well as hemoglobin concentration. So the SGLT2 mediated adaptations which might contribute to the cardiorenal protections are multiple. In the circulation, it can cause a decrease in plasma volume, and there is a decrease in arterial stiffness, and there is a decrease in systolic blood pressure of the tune of 4 to 6 millimeters of mercury, and as a result, there is also increase in hematocrit. And in the heart, this may result in decreased cardiac preload, decreased wall stress, and increased cardiac efficiency. And all of this can also, there is a decrease in inflammatory pathways, that decreased hyperfiltration. And so this may result in improved cardiac and renal function. And as a result, there is decreased cardiovascular outcomes, decreased risk of heart failure, hospitalization, and decreased albuminuria. So just elaborating further, what I already said, there is a tubular workload is reduced, and because of the proximal tubular reabsorption through SGLT is increased due to increase in luminal glucose driven by hyperglycemia and glomerular hyperfiltration. And this is active process and requires energy. And tubular hypoxia, as such, is a major mechanism for progression of kidney disease in diabetes. And by reducing the reabsorption, they reduce the workload and mitigate the hypoxia in the proximal tubule. And this lower middle oxygen and stimulates hypoxia-inducible factors, which may result in erythropoietin production and improving the oxygen carrying capacity. And there's glucose metabolic fluxes and mitochondrial dysfunction. Glucose metabolic flux increase in the kidney cortex in the experimental and human diabetes. And this process occurs by the increased proximal tubular glucose uptake. Moreover, because of the higher urinary levels of cyclic metabolites predict kidney disease progression, higher glucose metabolic flux promotes proximal tubular mitochondrial dysfunction. And because of the mitochondrial dysfunction, they may further aggravate the ATP deficiency and hypoxia, which could be activated, this could be elevated by the SGLT2 inhibition. And diuresis and natriuresis, because of due to the glycosyl and natriuresis, and this is an important mechanism which may reduce the blood pressure and risk for heart failure events. And again, the inflammatory, it also reduces the levels of various inflammatory markers. So those are the various mechanisms by which SGLT2 offers cardiorenal protection. A lot of trials have happened in SGLT2 over the last few years. The first trial was in 2015, and that was the EMPA-REG trial. And initial trials were cardiovascular outcome trials, which included the EMPA-REG, the CANVAS, and the DECLARE-TIMI trials. The CANVAS trial is in canagliflozin in 2017, and the initial cardiovascular outcome trials were in patients with type 2 diabetes, and they found improved cardiovascular protection. And the post hoc analysis of these trials showed that there was some renal benefit. So most of the trials looked into patients who had diabetes with normal renal functions and not much of proteinuria, but a subset of patients had lower eGFRs as well as proteinuria, and these patients were found to have improved renal outcomes. So this this paved the way for renal outcome trials. The first of which was the CREDENCE trial in 2019, and this was followed by the DAPA-CKD trial, and which was in 2020, and the recent the EMPA kidney trial outcome, which has come out in 2022. So these are the trials which looked into the cardiorenal benefits. So I'll be talking about few of these trials. So these are the initial cardiovascular outcome trials, which included the EMPA-REG outcome trial, the CANVAS, and the DECLARE-TIMI. These trials primarily looked at patients with type 2 diabetes and those with cardiovascular disease. EMPA-REG trial had patients with established cardiovascular disease. The CANVAS trial looked in patients with atherosclerotic cardiovascular disease as those with risk factors, and DECLARE-TIMI also looked into patients who had risk factors of cardiovascular disease. And some of these patients had a history of heart failure, and the average group was around 63 years. And in the EMPA-REG trial, the patients with eGFR less than 60 was around 25%. And in CANVAS and DECLARE-TIMI, CANVAS trial around 20%. DECLARE-TIMI looked into patients with normal renal functions predominantly. So this, when the post-hoc analysis was looked into, so they was found to have some renal benefit. So this was the outcome of these trials, where they showed significant related risk reduction in cardiovascular events around to the tune of 14%, and there was improved the mortality due to any cause was also improved in patients who were on SGLT2 inhibitors. Next, following these trials, you had the renal outcome trials, of which the first trial was the CREDENCE trial, which was based on canagliflozin. This came out in April 2019, and this was followed by the DAPA-CKD trial, which was in November 2020. Then the SCORE trial, which is the sotagliflozin, and finally the EMPA kidney trial. So just the highlight of these trials is CREDENCE, DAPA-CKD, and EMPA kidney. So CREDENCE trial had intervention was canagliflozin 100 milligram versus placebo, and the patient's population was those with type 2 diabetes mellitus and diabetic kidney disease. And the inclusion criteria was the patients with eGFR between 30 to 90, and the proteinuria of 300 milligram to 5,000. And they look at the primary outcome measures looked in was the development of end-stage kidney disease, doubling of serum creatinine, or cardiovascular or renal death. And in DAPA-CKD, This was dapagliflozin 10%, 10 milligram versus placebo. And in this, the currents looked only with patients with type 2 diabetes. Here, the patients with type 2 diabetes and non-diabetics was also included. And the EGFR was there is a lower EGFR up to 25 ml was also looked into, and the urine albumin creatinine ratio of more than 200. And the trial enrolled around 4,304 patients. And the composite outcome was ESKD, more than 50% sustained EGFR decline or renal cardiovascular death. And the EMPA kidney trial, here they looked into broader range of EGFR as well as albuminuria. So those patients included had diabetes, non-diabetes, and this was the largest trial. Around 6,609 patients were there, and they looked in patients the EGFR up to 20 ml per minute, and those with 20 to 45 and GFR, and those with more than 45 to 90 with proteinuria. So those which did 20 to this trial also looked in patients who had no proteinuria. So just highlight of these trials. So the Credence trial was a placebo, multicenter double-blind placebo-controlled trial where 4,400 patients who enrolled multicenter trial, and with type diabetes, with the GFR between 30 to 90, and with the proteinuria ranging from 300 to 5,000. So this trial showed that there is a decreased incidence of kidney-related adverse events, and which is highlight the renal safety of canagliflozin in patients with type 2 diabetes and CKD. And next is the DAPA CKD trial, which looked into patients. In addition to those patients with type 2 diabetes, they also looked into patients without diabetes also. The objective study was to assess whether treatment with dapagliflozin when compared to the placebo reduced risk of renal and cardiovascular events in patients with CKD with or without type 2 diabetes, and who are receiving the standard of care, which included a maximal tolerated dose of ARBs or ACE inhibitors. So the patients who were more than 18 years with the EGFR up to more than 25 ml, up to 25 ml per minute, and the proteinuria ranging between 200 to 5,000, and those who had maximum tolerated dose of ACARBs for more than 4 weeks, with or without diabetes. The excluded patients with type 1 diabetes, those with polycystic kidney disease, and ANCA vasculitis. So the dapagliflozin 10 milligram plus standard of care was compared with placebo with standard of care. And the primary outcome was the development of ESKD, or the sustained reduction of more than 50% of EGFR decline, renal or cardiovascular death. Second outcome measures were composite of cardiovascular death or heart failure hospitalization, as well as all-cause mortality. So in this trial, they had looked into overall population. Around 58 patients had diabetic nephropathy, and other causes of CKD was also looked into this study. Around they had patients with IgA nephropathy, FSGS. Around 6.3% patients had IgA nephropathy, and this study looked into patients with diabetes as well as non-diabetic CKD. So what you can see is that the graph shows that dapagliflozin significantly slowed the progression of as well as a risk of adverse outcomes. That related risk reduction was 39%. The primary endpoint was there's a reduction primary endpoint by 39% in patients who are on dapagliflozin. So treatment was there was based on the specified subgroups also looked into. So it was the benefit was seen in patients who had diabetes, those who do not have diabetes, those with proteinuria more than 1,000, and both with proteinuria less than 1,000, and those with lower GFR, as well as those with advanced stage of CKD. So this benefit was seen regardless of the proteinuria or the presence or absence of diabetes or the EGFR. And the all-cause mortality was also reduced in patients who are on dapagliflozin. There was 31% related risk reduction when compared to placebo. And this statistically significant treatment benefit was demonstrated in DAPA CKD across all primary as well as secondary endpoints when compared to placebo. Now, the benefit was also consistent and stratified based on the primary all-cause mortality, cardiovascular death, or the cause of CQD. So this benefit was seen across. And other thing was they also looked into patients with non-diabetic kidney disease, which included patients with IgA nephropathy. This and EMPA EMPA trial both included patients with IgA nephropathy, and as you can see, that a patient with IgA nephropathy, the benefit was seen with regard to kidney specific endpoint and the composite endpoint of chronic dialysis kidney and as well as kidney death. And regarding the safety profile of dapagliflozin, they found that some of the problems with SGLT2 inhibitors are one is the risk of amputations, which when there is no significant difference in the between the placebo and dapagliflozin group, and the risk of diabetic ketoacidosis was also not significant. There is no there was slightly increased risk of fractures. This was not statistically significant, and there were no significant major hypoglycemic episodes or in risk of volume depletion. Though it was present, it was not statistically significant, and there was no significant increase in risk of acute kidney injury. So that is about the DAPA security trial. So this showed that there was significant improvement in cardiovascular renal outcomes, and with a reasonable good safety profile. And next is the recent EMPA security trial. So this trial looked into a broad range of patients, which includes 6,609 patients with chronic kidney disease at risk of progression. This is a multi-centric study, and they looked at eGFR up to 20 ml per minute, and in those with proteinuria as well as without proteinuria. Empagliflozin 10 milligram once daily was given. So the baseline characteristics was the age of was around 64 years, and around 33% were females, and the patients around 46% had diabetes, and the cardiovascular disease was seen in 26% of patients. So the events when compared to placebo, the primary outcome events were less in patients with the empagliflozin, and as you can see, the risk of heart failure hospitalization was less in patients with on empagliflozin, and the cardiovascular death or deaths due to or heart failure hospitalization were less in patients who are on empagliflozin, and the cardiovascular events were also significantly better in patients on empagliflozin. And this also showed that the progression of kidney disease or death from cardiovascular diseases occurred in around 13.1% in EMPA group and around 16.9% in the placebo group. So at 2 years, empagliflozin reduced incidence of ESKD and the incidence of sustained decline in EGFR to less than 10 ml per minute, and the incidence of sustained decrease in EGFR of more than 40%. So this amounted to a 28% risk reduction. Again, the effect of empagliflozin with the primary outcome was consistent across the pre-specified key subgroups, those with and without diabetes, those across the range of EGFR, as well as the proteinuria. So the benefit was seen consistent across the pre-specified key subgroups, and benefits of empagliflozin were considered among patients with or without diabetes, and regardless of EGFR at the randomization. So that both these trials have shown significant cardiovascular renal benefits. Now, next is regarding the initiation of the SGLT2 inhibitor therapy in patients with diabetes. So this, according to the current guidelines, SGLT inhibitors can be initiated when the EGFR is more than 60 ml per minute. When the EGFR is more than 60 ml per minute, consider decreasing the insulin by around 10 to 20%, and also decrease the sulfonylurea dose in collaboration with endocrinologist. And you have to assess the volume as well as the blood pressure. The patients who are euvolemic and hypervolemic, you can start SGLT2 inhibitor, empagliflozin at 10 milligrams, and dapagliflozin in the usual 10 milligrams, and tenagliflozin 100 milligram. And you can continue the baseline AC as well as ARB or aminotransferase antagonist in most patients. And in normotensive euvolemic patient, you might have to decrease the loop diuretic dose by around 20 to 50%, and then up titrate as it is required. And the patient should be given 6-day counseling, and that is to stop the drug when in the events of any illness or any surgical procedure or any vomiting, diarrhea. So those are the times when the drug has to be stopped. And the follow-up blood work usually at the end of 1 month, which includes electrolytes, the creatinine and bicarbonate, and 30% initially 30% increase in serum creatinine is expected. And if the rise in creatinine is more than 30%, you may have to reassess the blood pressure, the volume status, and consider reducing dose of diuretics or improving the fluid intake or holding the SGLT2 or decreasing dose. And patients who are hypovolemic, you have to decrease the blood pressure medications and reduce the diuretic dose by around 20 to 30%, as well as liberalize the fluid intake. And the patient can be started on SGLT2 inhibitors when they are euvolemic. So again, the SGLT2 inhibitors have got benefits in patients with heart failure, and this has been shown by all the previous trials, as well as there are trials in DAPA heart failure trials. The recent Emperor reduced as well as preserved trials, which showed that benefits are seen in both with reduced ejection fraction as well as those with preserved ejection fraction. So this drugs, SGLT2 inhibitors have got a broad role in patients who are with hyperkalemia. SGLT2 inhibitors along with beta blockers and diuretics can be used, where the AC and ARB may have to be the dose have to be reduced. And in patients with GFR of more than 30 ml per minute, again, the SGLT2 beta blockers, diuretics, along with AC, ARB, and RNA can be used. And when the patient is having EGFR less than 30 ml per minute, now according to DAPA, up to 20 ml per minute, SGLT2 inhibitors can be used. So the SGLT2 inhibitors, beta blockers, and diuretics are useful in all these subset of patients. Now, going on to the adverse effects of SGLT2 inhibitors. One of the common adverse effects is genital infections. The patients are usually prone for mycotic fungal infections, especially elderly females are prone for mycotic fungal infections. And there has been increased risk of urinary tract infections also, although recent trials have not shown significant increase in urinary tract infections. And especially patients, elderly females are more prone for that. So these patients should be advised regarding the proper hygiene and cleaning the genital area before and after peeing, as well as drinking adequate amount of fluids. And usually mild infections can be treated and with antifungals, and the drug can be continued. And urinary tract infections also usually more prone in patients with obstructive kidney and elderly patients, those with males, females, and those with obstructive structural abnormalities. Those patients, SGLT2 inhibitors may be used with caution. And because of the volume depletion activity, the patients may be prone for orthostatic hypotension. And the risk of this volume depletion is more in patients who are more than 75 years, and those with the EGFR of less than 60 ml, and those who are using loop diuretics. And another side effect of this SGLT inhibitors are the euglycemic ketoacidosis, which is especially seen in patients with type 1 diabetes. And this is because it reduces the there is glucosuria, and this will create a pseudo fasting state, and this may promote ketogenesis and increase in glucagon. And my patient with type 1 diabetes, especially in setting of fasting, intercurrent illnesses, they are prone for this euglycemic ketoacidosis. And acute pancreatitis has been observed in patients with canagliflozin. The risk of fractures as well as amputations have also been found in earlier studies of canagliflozin, though recent studies have not shown significant increase in fractures or the amputation. But those with foot ulcers, significant POVDs used to use this drug with caution, with frequent attention to foot care. Now, if you look at the look at the what are the current indications for SGLT2 inhibitors? So the 5 categories of patients are benefited. One is to improve the glycemic control, as well as they reduce the metabolic risk, and reduction in the atherosclerotic cardiovascular events, which is shown in patients with type 1, type 2 diabetes, and across the EGFR categories, and reduction hospitalization due to heart failure, and those with diabetic kidney disease with albuminuria, and non-diabetic kidney disease with albuminuria. So patients who have CKD and without albuminuria, the absolute recommended as such, though the MPAC CKD has looked into those patients where there is a decrease in slope of EGFR, though the kidney specific outcomes was not significantly improved. What is the current KDIGO guidelines have to say? That is, in 2022, the KDIGO guidelines shows that the SGLT2 inhibitors can be used as a first-line drug therapy, as we initiate with the EGFR more than 20, and it can be continued until dialysis or on patient or transplant. And again, the ADA guidelines also used in patients with EGFR more than 25 ml or up to 20 ml as per the has 25 as per recent MPAC kidney trial, and urine albumin creatinine ratio more than 300. It's recommended to reduce the CKD progression cardiovascular events. So the 2020 guideline advice indicate SGLT2 inhibitor for patient type 2 diabetes and CKD who have EGFR more than 20 ml per minute, as opposed to 30 ml, which was seen in the 2020 guideline. Now, some special situations, SGLT inhibitors and potassium. The SGLT inhibitors may enhance the kaliuresis by increasing the distal allele sodium and stimulating the aldosterone. So, in credence, it was found, which include patient diabetes CKD on RAS blockade. This reduced the incidence of hyperkalemia, so that they have got that benefit. So, you can reduce the incidence of hyperkalemia by 23% without causing hypokalemia. So the need for new potassium binder usage was reduced in this trial by around 22%. And now other special situations, the role in type 1 diabetes. So though SGLT inhibitors have been approved in type 2 diabetes as well as non those without type 2 diabetes, in type 1 diabetes, there have been only few studies which looked into the beneficial of SGLT inhibitors. And one problem is that there is risk of euglycemic ketoacidosis, which can up to around 4% of patients may have. So, but still the benefit is there, and there are few studies. One was a tandem study, which was by sotagliflozin, where they found that there is a significant dip in EGFR at 4 weeks, and but there was improvement in proteinuria. And again, other analysis were EASE program, which was based on empagliflozin. So in this pooled analysis, those with urine albumin creatinine ratio more than 30 milligram, there was a decrease in albuminuria by 16%, and 30% which empagliflozin, a higher dosage of 25 milligram respectively. So the trials are there, which is looking into the beneficial aspect of SGLT2 inhibitors in type 1 diabetes. And regarding the role of SGLT2 in end-stage kidney disease, so there are a few trials which look in the role of SGLT2 inhibitors in dialysis patients. So the glycemic as well as the renal benefits may not, but the patient may have cardiovascular benefits. In patients, in animal studies, it has been found to reduce the peritoneal, the fibers, and improve the peritoneal ultrafiltration, and which may permit lower use of the glucose concentration in PD solutions. And this there's a decoded trial which aims to look at the cardiovascular benefits of dapagliflozin in hemodialysis patient. Though it doesn't look into the residual kidney function as an inclusion criteria. And now, again, in kidney transplant patients also, they are also at risk of cardiovascular mortality. So there's a potential role for these inhibitors in kidney transplant patients also. The Infinity trial is one trial which is looking into patients with patients with transplant. The problem, one of the problems is with increase of infections, but if it is carefully used, probably this can reduce the cardio. This can improve the cardiovascular outcome, and probably in the future it might be used in kidney transplant patients also. And regarding SGLT inhibitors and diabetic ketoacidosis, in type 1 diabetes, around 4 to 6% can have diabetic ketoacidosis. And all the patients who are initiated on SGLT2 should be counseled regarding the risk of diabetic ketoacidosis. And there are a few ways to mitigate this side effect. One is to stop the SGLT inhibitors 2 to 3 days prior to the scheduled surgery, and other is avoiding it more than 20% reduction in insulin dose, or carefully monitoring the insulin dosages, and avoiding this or stopping the drugs during episodes of acute illness, vomiting, or in the conditions where patient is unable to drink or eat. And following acute illnesses, SGLT2 inhibitors may be temporarily withheld and can be restarted up to 24 to 48 hours after recovery. And again, others concerned regarding acute kidney injury. But recent trials and real-world analysis have demonstrated reduction in risk of acute kidney injury. And real-world analysis comparing SGLT inhibitors with other anti-diabetic agents have reported the AKI risk was reduced by 21 to 53%. However, guidelines still continue to recommend that patients should follow the 6-day rule and stop the SGLT inhibitors during periods of illness or hospitalization. Finally, summarizing, SGLT2 inhibitors are the novel molecules which have got a broad range of use in patient diabetes mellitus and CKD patients. So this though it was initially started as a role with diabetic patients, it was subsequently found to have cardiovascular renal benefits in patients with diabetes mellitus, those without diabetes mellitus, those and reduce heart failure hospitalizations, as well as patients across the ranges of albuminuria as well as EGFR. And the SGLT2 inhibitors, along with ARBs and probably the nephindron and mineralocorticoid antagonists, are can play a significant way to prevent the progression of kidney disease in patient diabetes as well as in patients with CKD. Thank you.
Thank you, Jithin, for that excellent talk. Yeah, I think Jithin, you should proceed with the multiple choice question.
So there's one question which I've got for all of you. One is this is the case of a 41-year-old male who has been diabetic for the last 8 years, who was on a sulfonylurea and gliptins for the control of his sugars, and he's been hypertensive on telmisartan, which was restarted recently around 40 milligrams, and his baseline creatinine at the time of initiation was 1.8, and with the proteinuria of 900. And after 1 month of starting telmisartan, the lab values were rechecked, and it was found that his creatinine had gone up to 2.1. Which is 30% rise, and there is a serum potassium of 5 milliequivalents. Now, what would be your next step of management? One, would you continue the angiotensin or the telmisartan in the same dosage, or you increase the ARB dose from further, or you stop the ARB and start an SGLT2 inhibitor, or would you reduce your ARB dose and add the SGLT2 inhibitor? So, as you all can see, when you started the patient on ARB, there was a rise in creatine, which is a tune of around 30%, which is expected. So there's no need to panic, and the ARB need not be stopped. In fact, you can continue ARB in the same dosage. But there would be a scenario where the creatine must have gone beyond the 30%. So in that situation, probably you might have to stop an ARB or reduce the dose of ARB and start the SGLT2 inhibitor. So that's my take on this. I would like to know the opinion of the house.
I think we'll start the discussions later once we finish with the quiz also, because we are running short of time. Are you done with the MCQs, Jithin?
Yes.
Yeah, over to Kishore for the quiz.
Good evening, and Jithin, can you, Dr. Jithin, can you stop? Stop the share screen so that I can share my screen. Okay. Okay. Can you see my screen?
Yeah. Yes.
Yes.
Good evening. Let me thank Dr. JKN for this innovative educational idea of adding two quiz questions onto this topic. This evening, I will present two questions on trivia about SGLT2 inhibitors, and should be something somewhat easy for fluosinators. So those who can, the 30 seconds after the question, you can type the answers in chat box and discuss afterwards. So the first question here is, the natural SGLT2 inhibitor was developed in 1835 from. So these are the options. One is Gila monster saliva, bark of apple tree, French lilac, or foxglove. So what could be the answer? The natural SGLT2 inhibitor was developed from which source? Which natural source of these? Can Dr. The two answers, one is what is French lilac, village bark of apple.
Everybody is going for bark of apple.
Not
So let me go to the answers. Answer.
Yes, sir. Yes.
So the natural SGLT inhibitor was developed in 1835 as fluorescein. All of us have studied in our physiology classes about fluorescein. And fluorescein was developed from the bark of apple tree. As this is one of the studies on actually, it was actually tried for malaria also. As bark of apple tree, pear, plums, and all. And it is actually only in 50 years later, in 1885, it is shown that it can cause glycosuria. Gila monster saliva is classically for incretins or exenatide. There is a precursor of exenatide is from Gila monster saliva. French lilac is bigvenites. It's actually in natural for the preparation for diabetes. It is something called Galega officinalis, or it's a bigvenite or metformin. This precursor is seen in French lilac, and foxglove, as we all most of us know, is digitalis. So coming to the next question, the answer is bark of apple tree. Coming to the next question, it is in the 1960s. In Prague, this discovery of sodium glucose transport was actually as a mechanism of intestinal glucose absorption was made. This is huge implications. Robert Crane made this presentation. This is huge implications, not in diabetes, but in the treatment of another disease, which saved lots of lives at that time. It's way back in 60s. Can you identify the disease, or what was the treatment? It is a guess. Even a guess can get an answer. It's a you can guess even it is wrong. Tropical screw, no. Anybody else? So okay, I will go to the answer. It was oral rehydration therapy. Yeah, exactly, Dr. Asha. That is a correct answer. That is cholera is the answer. It's oral rehydration therapy for cholera, and that is based on the sodium glucose transport mechanism for intestinal glucose absorption. Thank you.
Good ones.
Yeah, thank you, Dr. Jithin, for that excellent and comprehensive presentation. And thank you, Dr. Kishore, for that quiz. Really appreciate it. Since we are running short of time, we will just have a few inputs